Hello everyone. Today our topic will be about gestational DM, which is basically one of the important topics that you should have knowledge about as a medical student, and also every pregnant woman should have this information. As simple as the definition is, gestational DM is a carb intolerance of variable severity that is first recognition during pregnancy. And of course, this definition involves some women that have overall DM, either type 1 or type 2, and didn't know about it until this pregnancy. For the etiology, we will mainly talk about placenta, its hormone, and beta cell inside the pancreas. This is actually a simple drawing of placenta. So, mainly the etiology, as we say, it is placenta and pancreas. What placenta will do is will secrete what is called a diabetogenic hormone. This diabetogenic hormone will try to increase insulin resistance so that a good amount of glucose, rather than taken by the pregnant, will go into the fetus to feed the fetus. And these mainly diabetogenic hormone are growth hormone, human placental lactogen, progesterone, and corticotrophin releasing hormone. So these will try to increase insulin resistance. One of these hormones will do other job, which is increase insulin amount by stimulating beta cell pancreas. All of that to maintain this pregnancy. Okay, so the pregnant woman will have some of this glucose to enter inside her body, inside her cell. So there will be increased insulin amount to compensate this insulin resistance. That is all in normal pregnancy until the baby comes. But in cases of human placental lactogen stimulate a dysfunctional beta cell. Okay. So dysfunction in beta cell will not stimulate by human placental lactogen, and the insulin amount will decrease, or it is not sufficient amount to compensate that increase in insulin resistance. And that is what's called gestational DM during pregnancy. Okay? So that not occur actually in every woman, but mainly in the women that having a risk factor. And these risk factors are mainly who having a BMI more than 30, when the age is more than 25, and there is a strong family history of gestational DM, or there is a history of stillbirth baby also. These are risk factors for gestational DM. Other mechanism that could lead to gestational DM is obesity by itself, not that lead to pancreas dysfunction. Obesity by itself, so let's draw obese woman. So this is a simple drawing of an obese woman that we will explain through it. when free fatty acid accumulate in the bloodstream, it will enter the muscle cell and the liver cell. And when free fatty acid enter the muscle cell, it will disrupt the signaling that will happen inside the cell. And what I mean about the signaling is actually when insulin bind to its receptor on the muscle cell, it will allow the glucose to enter into this muscle. This cell will move what is called GLUT4 movement into the membrane that will allow the glucose to enter this cell. But when free fatty acids are inside this cell, it will disrupt all that signaling and it will be blocked. So glucose will not enter the muscle cell and it will accumulate in the bloodstream in the high level. So that's one reason why obese women result in hyperglycemia. The other cause is when the free fatty acid enter the liver. Free fatty acid actually considered as a fuel to liver, because when free fatty acid enter the liver, it will give energy, and this energy will stimulate gluconeogenesis. So glucose production will increase and also will result into accumulate of glucose in the bloodstream. And that's why end up with hyperglycemia, because of insulin resistance that is already happened during pregnancy and normally happened, and also due to increase of glucose level due to, as we said, when free fatty acid enter the muscle cell, it will block the signaling, and also when free fatty acid enter the liver cell, it will release more glucose by gluconeogenesis. The complications are actually mainly as at the top of them is preeclampsia, preterm baby, increased risk of postpartum hemorrhage, increased risk actually of cesarean delivery and stillbirth baby. But if we diagnose it early and get the management, so all of these will have decreased in a significant amount. And now we will talk about the diagnosis and then the management. So pregnant women need to diagnose as early as possible if they have a high risk factor. And for the diagnosis, we need to assess the risk for each woman. And the risk actually divided to low risk, average risk, and high risk. For the low risk, the women having normal weight during pregnancy and before pregnancy. There is no family history. Of gestational DM, and there is no age, so let's say the age less than 25. For the average risk, the woman could be overweight but not very high overweight, so let's say slightly overweight, could have a family history but not first degree relative, so there is family history but not strong. Or the age more than 25. But otherwise anything are normal. In cases of high risk, when the woman having severe obesity, having a first degree relative, or age more than 25 and also having these risk. So for diagnosis, in cases of low risk, the diagnosis no need actually, let's say for low risk women, there no need for screening because they have a very low probability to having gestational DM. But in case of average risk, they will need a 24 weeks to 28 weeks to have a screening. And we will talk about screening criteria. In cases of high risk, as soon as possible. And the way that for diagnosis, we will actually follow the National Institute of Health and the American College of Obstetricians and Gynecologists. And they both say that they both recommended the two-step approach. The two-step approach began with actually 50 grams of glucose. The pregnant will take, and we don't care about the last meal, so she will come to us with her daily food and take in 50 grams of glucose. We will wait 1 hour, then we will take a blood glucose test. If the result is 135 milligrams per deciliter or 140, this will need us to go into the second step, which is glucose challenge test. These both results, actually what the hospitals depend, some hospitals depend on 135 and other will depend on 140. The 135 is actually better in sensitivity, but it is less specificity than 140. Here we will depend on 135. So now any patient had result of 135 or more, she had to go into the second step, which is glucose challenge test. If she had lower than these results, there is no need to other test. Actually, unless she is a high-risk patient, then repeated this test at 24, 28 weeks is mandatory. Because pregnant with high risk, they have to do this test at prenatal visits or as soon as possible. And if result is normal, they should repeat it, then it should be repeated at 24, 28 weeks. So let's do a quick recap. Low-risk women, they need no investigation, and women with average risk, they have to do at 24 to 28 weeks. And for women with high risk, they do as soon as possible or at first prenatal visit. And if it is normal, then they should repeat it at 24, 28 weeks. And now, if she had either result, she have to be fasting at least 8 hours, but not more than 14 hours. Okay. And the last 3 days should be an unrestricted diet. So this is first one and second one. So more than 150 grams of glucose taken daily. And birthday. And there should be also a physical activity. The woman should not smoke. And the fasting result at the morning should be at least 92 milligrams per deciliter. And she will take after that 100 grams of glucose. Then she will wait 1 hour. Okay, so after 1 hour, she waited, she will have another blood test. Blood test that should result with 80 milligram per deciliter. And she should have also the 2-hour test that should at least be 55, sorry. And the third one should be 140 milligram per deciliter. 2 of these will be enough for diagnosis. Now we will talk about the most important part, which is basically the management. Management is very important, and we should talk about it in details. Management have many parts, and the first part is monitoring. And I mean by monitoring is the pregnant herself will every day make 4 blood tests. So each day she will have 4 blood tests inside the home. One should be fasting at early morning before breakfast, and the other 3 will be 1 or 2 hours after each meal. This will let her to monitor her blood glucose level, and by that will modify her diet according to the result that she will get. We want a fasting blood level less than 92 milligram per deciliter, and the 1 hour should be postprandial, should be less than 140, and the 2 hour also postprandial should be less than 120 milligram per deciliter. And by diet modification, the woman should have 20% of her food as a protein. And 40% will be fat. And the remaining, which is basically 30 up to 40%, should be calories. And these 30 to 40% better to be a complex carbohydrate and dietary fats. This will be a better outcome for the baby. And in 2004, Brankiston and its associates found that resistant exercise in overweight women and have gestational DM will diminish the need of insulin therapy. So resistant exercise, there is decrease in insulin need therapy. And in case that women will not able to achieve this level of blood glucose every day, so there will be a persistent exceed of blood glucose at fasting more than 95, or 1 hour postprandial will be more than 140, or the 2 hour will be persist at more than 120. Here we will turn into medical treatments. Medical treatment will be actually the first line treatment is insulin, because insulin is not cross the placenta, and insulin dose should be 0.07 to 0.1 unit per kg. The insulin dose should be divided into morning and evening. Morning will take the 2/3 of the dose, and the rest 1/3 will be at evening. The 2/3 of the dose will be 2/3 of it regular insulin, and 1/3 will be NPH. Okay. 1/3 at the evening will be actually half regular and half NPH. The second line is either metformin or glyburide, but actually both of them is not FDA approved, so we will not talk about it. And would be the end of our lecture. Thank you for your listening, and please subscribe our channel.